Esteemed faculty and dear delegates, a very good evening to one and all. I, Dr. Tanmay Rane, feel very privileged to welcome you all on behalf of the entire team at Emcure Pharmaceuticals. We at Emcure are proud to present Empower Talk, our highly anticipated scientific program dedicating to exploring the multifaceted landscape of diabetes management. This program serves as a bridge between knowledge and practical application aimed at equipping us with the tools needed to enhance the life of patients affected by diabetes. Our distinguished speaker today is poised to share his knowledge, insights, and practical wisdom to empower us in the fight against this health challenge. We are thankful to our esteemed speaker, Dr. K.M. Prasanna Kumar sir, who has generously decided to share his time and wisdom. Emcure is privileged to have a role in facilitating this bond. Let me now have the privilege of introducing our esteemed speaker for the program, Dr. K.M. Prasanna Kumar sir. Sir is a consultant endocrinologist at the Center of Diabetes and Endocrinology, Bangalore, former senior professor and head endocrinology at MS Ramaiah Medical College, Bangalore. Sir was the president of RSSDI from 2007 to 2009, Endocrine Society of India from 2008 to 2009, Indian Thyroid Society from 2017 to 2019. Sir was also the vice president of Endocrine Society of India from 2002 to 2003, Indian Thyroid Society from 2013 to 2014, RSSDI from 2004 to 2007. Sir is the chairman of Changing Diabetes in Children in India from 2011 to 2014. Sir was part of the scientific committee. Sir was the scientific committee chairman of RSSDI in 2003, executive committee member RSSDI 2001 to 2004. Sir has more than 175 publications in national and international scientific journals, has been the principal investigator in more than 150 global clinical trials, and has been responsible in several early pioneering work in translational research. So has also been on the editorial board of International Journal for Diabetes in Developing Countries. And finally, I would also like to extend a warm welcome to all the delegates who have joined today's program. It is an honor to have such an esteemed audience and renowned experts among us. Let me now brief you on the agenda for today. We will have the session by the expert speaker, followed by a... Therefore, I request the audience to post their questions in the comment box so that we can take up those questions later. Without further ado, let us embark on this educational voyage together as we endeavor to enhance our understanding of diabetes management. I would now request our expert speaker, Dr. K.M. Prasanna Kumar sir, deliver his session on role of pioglitazone based combination therapy in diabetes management in the current era. Over to you, sir.
Good evening, everybody. Thank you, Dr. Tanmay Rane, and welcome for this session on pioglitazone and the comment. Let me share the screen. Can you see the full screen?
Yes, sir.
So, good evening, gentlemen and ladies. Doctors, today we are discussing role of pioglitazone-based combination therapy in diabetes management in the current era. Lot of things have changed in diabetes, from prevalence, incidence, management, and care also. So I'm going to talk about little diabetes management, pioglitazone-based therapy. What is the clinical evidence for this? Combination with metformin, combination with gliptin and others. As all of you know, that today in 2024, the prevalence of diabetes is increasing, and today we have 113 million, 11 crores, or almost 10 crores of diabetics and 11 crores of pre-diabetes. And by 2045, it is going to increase much more to 124 million. From 100 million, it will go to 124 million. So also pre-diabetes, which is impaired glucose tolerance, from 113 may go up to 140 million as such by 2045. Now, what we have to see today is how the residual risk is there in these patients And what are the unmet needs of diabetes? The one is there is a combination of multiple pathophysiological mechanisms, and these mechanisms have to be addressed where we have to multi-pronged attack to bring down blood sugar, and treatment provides both glycemic and extraglycemic control. And this treatment should not have hypoglycemia. It should reduce the weight or avoid weight gain, and tablets improving the compliance, because injectable are there, compliance is poor, they are expensive. Most important, residual CV death, and also it should protect the liver and the kidney. So let us see what we have got today with this. Now, all of you know we have seen hundreds of times this octet, where the pathophysiology of diabetes is almost 6 to 7 or 8. It is even 12 also, whether it is pancreas, intestine, fat cells, kidney, muscle, brain, liver, all these things can affect. So, how this pathophysiology can be addressed with multiple, not by single drug. So, coming to diabetes management as all these days, we had one drug, start with metformin 250, 500, 1000, 2000, not controlled after 3 months, go to second drug, third drug, and all. Now it has changed. If you look at the AACC, American Association of Clinical Endocrinologists, it says if at the beginning, today I see a newly detected diabetic, less than 7.5, take one drug, 7.5 to 8.5, two drug, 8.5 to 2, three drugs. If the HbA1c more than 10, then you start insulin. So less than 7.5, one drug, metformin. Two drugs, then you see two drugs, you will see between 7.5 to 9, and 9 to 10, three drugs. Above 10, you should use insulin. This is what yes guideline says, but stepped care approach. And this is it also says. It depends on the cardiovascular risk. If the patient has atherosclerotic cardiovascular risk, you can use metformin with DPP4 inhibitors, SGLT2 inhibitors, and GLP-1 unlock. If there is a renal problem, SGLT2 inhibitors are the best. If cardiac one, then GLP-1 receptor unlocks are preferred over that. This is what I don't want you to go through all this, but this is the summary of it. So what is the need for newer combination? As I said earlier, unless it is less than 7.5, one drug will not. Combination therapy in hypertension and diabetes from the beginning is the most important thing. Type 2 diabetes, as I told you, is complex disease underlined by multiple pathogenic defects responsible for development and progression of hyperglycemia. Each of these factors can be tackled in more targeted manner thanks to glucose lowering drugs that have been made available past 2-3 decades. 50 years back, when I did my MBBS, at that time we had only two drugs, metformin, sulfonylurea, simple. Today we have 10 to 12 alternatives, including bariatric surgery. And each of these will answer different pathophysiological mechanisms. Recognition of the multiplicity of the mechanism underlying hyperglycemia calls for treatment that addresses more than one of these mechanisms, with more emphasis placed on early combination of therapies. Many times, even at 7.5, we can use multiple drugs without hypoglycemia, which will answer that. As I said 50 years back, diabetes means we knew only one thing, either insulin resistance or insulin deficiency. So sulfonylurea was used if there's insulin deficiency, metformin is used if there's insulin resistance. The whole concept has changed 1970, 80, 2000, 2024. Why is it that we are interested in pioglitazone? Pioglitazone is important because patients with diabetes have dual effect, as I told you, both insulin resistance and beta cell function. What starts when the weight increases, insulin resistance converts between normal glucose tolerance to impaired glucose tolerance, pre-diabetes to diabetes. Once diabetes starts, it's not increasing insulin resistance, beta cell dysfunction. So we need drugs which will address both. Thiazolidines, we had rosiglitazone, now it is no longer there. Now we have pioglitazone, reduces insulin resistance by its action on the PPAR activated receptors as such. Please remember, metformin is not reducing insulin resistance. Metformin mainly acts by reducing the hepatic glucose output. It also reduces appetite. Thiazosardines preserve beta cell because they are the drug which reduce insulin resistance. Pioglitazone is a thiazosardine group that provides appropriate monotherapy or in combination with other drugs, metformin, gliptin, SGLT2, anything you can combine to achieve a good control as such. Studies up to 32 weeks, that means almost 6 to 8 months, have shown that pioglitazone significantly reduces A1C and fasting plasma glucose when used alone or in combination with other anti-diabetic drugs as such. There are trials which up to 1 year, that is 52 weeks, involving 3,700 patients of type 2 show that pioglitazone effective long-term treatment both as monotherapy and combination. When we use a drug, we have to see a drug which does not cause hypoglycemia. The most thing is durability. Sulfonylurea durability is poor. Metformin is good. When they did study with sulfonylurea, metformin, and glitazone, it shows glitazones had the longest durability. In fact, that study was done with rosiglitazone, not with pioglitazone. But both are same group. So pioglitazone confers benefits in terms of improvement in fasting insulin, lipid parameters, preserves beta cell, improves C-peptide, and 30 to 33 split proinsulin and hypoglycemia versus other monotherapies were used and all that. So it is well tolerated. Pioglitazone well tolerated, low incidence of adverse effect. We have got almost 3 decades of experience. Long-term data support concept that pioglitazone should be used earlier treatment of type 2 diabetes, either as monotherapy or it in combination as Ralph DiFranco, he is coming to India last 20 years. I met him last in Hyderabad. He is one very fond of pioglitazone. Even today, what is known as triple therapy, what is known as DiFranco regimen. If the HbA1c at the beginning is 11, not even 10, DiFranco used metformin, pioglitazone, and he also used liraglutide, daily injection. He showed that liraglutide, metformin, pioglitazone used, even HbA1c level can be brought down to nearer to 7. This is DiFranco's triple therapy. And he also showed that pioglitazone is a potent insulin sensitizer, preserves beta cell function, causes durable reduction in A1C, corrects multiple components of metabolic syndrome, and improves non-alcoholic fatty liver disease. So now NASH has been divided with MASLD, metabolic disease associated liver disease. So that is why it is called MASLD, metabolic syndrome associated liver disease, MASLD. NASH and NAFD has been changed by MASH and MASLD as such. So adverse effects like weight gain, fluid retention, fracture, to some extent anemia are diminished with lower doses and are arguably outweighed by the multiple benefits. For every drug, you have to see cost-benefit ratio and benefit versus side effect as such. No doubt, these are the minor side effects of pio, but the benefits outweigh the side effect. With healthcare expenses attributable to diabetes increasing rapidly, you have got GLP-1 unlock costing 10 to 12,000 rupees per month, injectable or oral, and this cost-effective drug requires reconsideration in therapeutic armamentarium for the disease. Pioglitazone is one of the most economical drugs. Now, what is the protective effects of pioglitazone in terms of different actions? 40%, 47% reduction in secondary stroke in patient with previous stroke. Then reduction in CAMT, that is carotid intima media thickness by the in Chicago trial. 28% reduction in reinfarction patient with previous MI, proactive study. 37% reduction acute coronary syndrome after previous MI. And again, stop progression of coronary atherosclerosis known as periscope study. These are all studies done last 1 to 2 decades. And also that pioglitazone reduces MI, stroke, and death in patients with chronic kidney disease. 51% reduction mortality in patient with hemodialysis, and also the quartet study showed that pioglitazone reduces the microalbuminuria in these patients. Reduction of inflammation, necrosis, NASH, non-alcoholic steatohepatitis. Now it is called as metabolic syndrome associated alcoholic steatohepatitis, and 50% reduction in hepatocellular carcinoma. So metformin and pioglitazone have a effect that it reduces the malignancy as such. This appears to be a little crowded slide, but just remember its effect on the intima media thickness. I told you blood pressure, circadian rhythm, and hydric hemostasis, adipose tissue, coronary artery disease, lipids very important, endothelial dysfunction, arterial stiffness. All these effect of pioglitazone on vascular system and CV risk scores. Pioglitazone has gained popularity after several clinical trials reporting reduction in atherosclerotic, AFib, and atherosclerotic-related events. Also positively modulates numerous CV function risk factors such as blood pressure, blood lipids, adipose tissue, physiology, and slowing down the atherosclerosis. If you have any question, please put it in the chat box. I will answer it, or you can unmute and ask me at the end of my presentation. Let us look at pioglitazone and establish one. Pioglitazone is the only true insulin sensitizing anti-diabetic agent. So metformin is not insulin sensitizer, but pioglitazone is. Metformin, as I told you, works on liver, reduces hepatic glucose output. These CV risk factors are obesity, hypertension, hypertriglyceridemia, low HDL, small dense LDL, endothelial dysfunction, hyperglycemia, inflammation, that is increased HSCRP, lipotoxicity, how the fat cell become toxic cells and lipotoxicity occurs. NASH, NAID, NAFLD, and PI1 and hyperinsulinemia, insulin resistance. All these are affected because pioglitazone decreases all these things, increases HDL, as you can see here, improves the NASH, and these are all the things. So what are the CV risk factors? What is the effect of pioglitazone? Now, as I told you, risk and benefit ratio. What are the risks? Yes, weight gain. It is not too much, 1 or 2 kgs, but decreases visceral fat more than the parietal fat, hepatic and muscle fat content, fluid retention can be. That's why you should not give pioglitazone when there is heart failure. There is a long-term study which shows if it is trauma related, it can cause only long bones, the fracture incidence increases. Blood cancer, the bladder cancer was not established. I'll show you the data, how it is there. So potent and durable events reduction is the benefit. Lower or least hypoglycemia, improves insulin resistance, improves beta cell preservation in the long term, and durable drug prevents conversion of IGT or pre-diabetes to diabetes, and improves CV risk factors, increases HDL, reduces triglyceride, reduces blood pressure, reduces inflammation, microalbuminuria. These are all CV risk factors. And also, directly it has shown decreases cardiovascular events in high-risk patients, proactive status, high-risk health, meta-analysis, and reduces cardiovascular events in diabetic patients with chronic kidney disease, improves endothelial dysfunction, NASH and NAFLD. Thus, as you can see, these are all the potent benefits compared to minor side effects. We'll come to that later on as such. So, rethinking of pioglitazone as a cardioprotective agent, this is what it is. With appropriate prescription titration, pioglitazone remains a useful tool in the arsenal of diabetes management. So why this pioglitazone combination? As we change to a new evidence-based era of type 2 diabetes, it is imperative we choose therapy not only improves the glycemic control, but also improve CV outcome. CVOT trials. When pioglitazone was introduced, rosiglitazone was introduced, there was no CVOT trial. From 2010, last 15 years, that CVOT trials have come. Pioglitazone has been shown to reduce MACE, that is MI, stroke, CV mortality in multiple studies to reduce CV events mortality, though it has not undergone CVOT trial. Pioglitazone is the only insulin sensitizing agent that has a potent beneficial effect to improve and preserve beta cell function, leading to durable reduction in A1C as such. Right? So pioglitazone also corrects multiple components of metabolic syndrome and is an effective treatment for NASH and NAFLD. Side effects are there but can be mitigated by optimizing the dose or combination with others like metformin, sitagliptin, because metformin also reduces the cancer of all types in type 2. So the benefit to risk ratio of PIO is very favorable when caution is employed toward the known side effect of the drug. Now, let us look at pioglitazone DPP-4 inhibitor. Pioglitazone seems to be a logical agent to combine with other oral antidiabetic agents, including DPP-4 inhibitors. And DPP-4 inhibitors may also have a potential to preserve beta cell function. Available as a fixed dose combination with pioglitazone could be potentially attenuate some of the side effects of pioglitazone, particularly lower dose. See, all over the world they may use 30 and even some of the countries use 45. We never have 45. We start with 7.5, 15 maximum have used 30 milligrams. Why this dose is important, not use higher dose, I'll come back to. So when you use metformin pioglitazone, it effectively treats insulin resistance. Different insulin sensitizing mechanisms of metformin, thiazolidines are manifest in partially distinct effects on hepatic and peripheral glucose homeostasis, as I told. Clinical studies also show improvement in glucose control with this combination. You already have last 10 years many of these. Both metformin and pio may also have pancreatic beta cell preservation as studies have shown. They have different beneficial effects on several other metabolic risk markers and risk factors for cardiovascular disease. So both of them treat insulin resistance, but pioglitazone is a better insulin sensitizer compared to metformin. And also effects on dyslipidemia, and metformin reduces appetite for some time. And they have a distinct effect on mediators, that is inflammatory markers, endothelial dysfunction, and outcome studies have shown either PIO or MET may reduce risk of macrovascular disease. So the complementary mechanism of action of MET and THIO or pioglitazone provide opportunity for effective combination. It is one of the combination till used today. Now newer combination have come. Such combination has consequences not only on improved control, but also reducing metabolic risk, potentially improving the cardiovascular outcome. Coming to clinical evidence, I will not go into too much of detail. This is a study where pioglitazone and long-term effects in type 2 comparisons, like if you see here, HOMA model as such, as you can see here, pioglitazone regime resulted in improved sensitivity and more favorable compared to GLIC-based therapies as such. That is glycoside-based therapy. As you can see here, HOMA model, this is what you see here, the glycoside compared to pioglitazone. These benefits may be important management of CV risk as such. Again, you will see the impact of this pioglitazone on insulin resistance. You have metformin here, metformin, pioglitazone, dapagliflozin. All these studies have shown fixed drug combination of metformin, pioglitazone provide better improvement in insulin sensitivity than metformin alone, or similar changes in insulin resistance with dapagliflozin in overweight individuals with type 2. Further study with substantial sample, longer follow-up are necessary to prove this point. But this small study shows that the metformin-pioglitazone combination is good. If you look at combination of sitagliptin and metformin or pioglitazone, look at this HbA1c reduction. When you look at placebo and sitagliptin, you will see that sitagliptin has a good reduction in A1C. So also you can see here, add on pioglitazone. When you add pioglitazone to sitagliptin, you can see much better A1C reduction from 8 to 7.2 here. Here also 8 to 7.4. So this is a 24-week study of metformin and with pioglitazone and also with the sitagliptin as such. So efficacy safety of pioglitazone randomized study in 26 weeks of type 2 diabetics, 313 patients to assess efficacy safety of sita in combination with metformin and pioglitazone. So you look at these patients, multinational randomized trial primary outcome was change in HbA1c at 6 weeks. When you look at 26 weeks, as you can see, sitagliptin here, and compared to placebo. Addition of sitagliptin 100 mg per day to combination of metformin and pioglitazone led to significant change. These patients were already on metformin pioglitazone. You added sitagliptin, then you see this. Whereas adding placebo, that A1C did not come down. So thus, triple combination therapy was well tolerated, low incidence of hypoglycemia, no meaningful change in the body weight versus dual combination. So this study showed 26 weeks triple combination of metformin, pioglitazone, adding sitagliptin showed significant reduction in A1C from 8.8 to 8.6 to almost 7.6. There is another study to compare efficacy and dual antihyperglycemic combination to find the most effective and efficient method to treat 160 patients type 2, not well controlled, actively treated with metformin. 12 weeks of randomized open trial where sitagliptin was added and primary outcome was A1C reduction. Sita and Pio demonstrated similar improvement in glycemic control. Type 2 whose blood sugar inadequately compared to metformin. Sita was more effective than pioglitazone regarding lipid and body weight change because the gliptins are weight neutral and pioglitazone may increase 1 or 2 kg. This is another study to evaluate triple oral therapy between metformin, pioglitazone, sitagliptin and metformin, pioglitazone, glibenclamide. 476 patients. Primary outcome is to see A1C reduction, beta cell function. So Sita should be preferred to glibenclamide as an addition to metformin because glibenclamide causes hypoglycemia, weight gain. Pioglitazone combination for its better protection of beta cell and neutral body weight. This is a 3-year study to evaluate triple oral therapy using useful in glycemic control compared to metformin monotherapy. So when double therapy is not useful, triple therapy can be used. I don't want to go into details. This is a study which demonstrates CV risk indicators like age and rage, and these are the ratio which are improved when you use this glimepiride compared to metformin and others and pioglitazone. This is a long-term 2-year study of safety efficacy trials of Sita plus Pio. As you can see here, initial combination therapy of Sita and Pio produced better glycemic compared. Again, triple therapy with Sita and metformin and others was much better. And these are the again 2-year studies, Sita Pio combination better. These are all different studies. That is Henry 2004, D. Rosa 2013, Alba 2013, Yun et al. 2012. All these studies show that Pio with Sita is a good combination. So Sita Pio combination type 2, this is 54 weeks, 1-year study. Baseline and extension study, as you can see. Initial combination of Sita plus pioglitazone had a good control. And also you can see here that even as far as 1 year, that it was maintained, durability is good. So this is a comparison of DPP4 and Pio combination versus pioglitazone monotherapy. This is a meta-analysis of 7 randomized controlled trials. Combination was associated with increased A1C reduction and was not associated with higher risk of hypoglycemia, edema or anything. This combination therapy of Pio and DPP4 Sita was associated with better beta cell preservation as such. As you can see at this dual combination of sulfonylurea, pioglitazone or DPP4, and this is a Korean study as such. So these studies show proportion of individual with overall successful rate to the baseline as such. And the last concern is bladder cancer. About 5 to 8 years back, they said a black box warning is given that if pioglitazone is used, that you should be careful about bladder cancer. Now, last 5 to 8 years, many studies have come. This is a global study which showed Shashi Bhushan and others. India has a very low prevalence of overall bladder cancer, specific pioglitazone related adverse effects as such compared to Europe and America. Possible explanation why bladder cancer is less rates include variance in genetic makeup. We are different from European Caucasian population, have very high bladder cancer. Pioglitazone prescription at a lower dose is the one, and higher frequency of metformin is concomitant drug. As I told you, we don't use 45 mg. 7.5 is available in India, 15 mg, 30 mg. Maximum we use 30 mg. America had the highest relative percentage of suspected bladder cancer in these patients, 53%, whereas prevalence was much 2% of this pioglitazone-induced the bladder cancer. Metformin itself is anti-cancerous, as I told you, and its use along with pio may contribute to less of this. So these are many things which showed Dr. Mohan Vishwanathan has published this study, the correction between pioglitazone and bladder cancer seen with if the therapy is more than 2 years. Cumulative dose of 28,000 milligram. That means daily dose of 40 milligram. We don't use such a high dose. Doses in USA, as I told you, 30 to 45, India 7.5 to 30 per day. So in India, we generally do not use greater than 30 milligram, as I told you, and we don't need a 28,000 milligram. So low dose pioglitazone is probably responsible for very minimal bladder cancer, those who are taking. So we may continue the use of this drug as a second or third line along with metformin and GLP, DPP-4 inhibitor. So let us now come back to triple therapy of metformin, sitagliptin, pioglitazone. As I told you, this octet, what are the things that is said? DPP-4 inhibitors acts on the pancreas. DPP-4 inhibitors will protect them. DPP-4 inhibitors acts on the incretin effect. DPP-4 inhibitors also, along with other drugs, will say most of these things like metformin and glitazone will act on the muscle. Metformin, glitazone acts on the liver. Metformin, DPP-4 acts on the pancreas, and metformin, glitazone acts on the fat cells. So if you look at all that, except on brain and kidney, the action on the brain is mostly by GLP-1 receptor unlock, and SGLT2 inhibitors acts on the kidney. Except these two mechanisms, out of 8 mechanisms, 6 mechanisms are countered pathophysiology by metformin, sitagliptin, and pioglitazone. So this is how all these things will act, except on brain and kidneys as such. So to summarize my talk, the multitude of therapeutic options for type 2 diabetic adds to complexity of managing patient with type 2 diabetes, but also allows clinician to readjust and rebalance treatment over a time as physiological changes occur throughout the disease. As understanding of pathophysiology type 2 from only 2 pathophysiology, insulin resistance, insulin deficiency, we have gone to 8, the octet. Now we have got even 12. I don't want to go into mitochondrial and other mechanisms. It is becoming apparent early use of targeted combination therapy has beneficial potential effect to slow down the disease progress, protect the target organ, and correction of known pathophysiology, most important, preserve the beta cell. Whereas the underlying pathophysiology type 2 should be a key factor in choosing which medication to combine. Insulin resistance has to be reduced, and beta cell has to be preserved, and even the liver has to be protected, and intestine also it should work. It should work on the fat cells and protect the myocardium as such. And based on individual therapeutic potential, newer therapies are appropriate for use in combination with traditional agent. What is the traditional agent? Metformin and pioglitazone. And the third one, sitagliptin, reduce A1C without increasing the risk of hypoglycemia. This combination of pio, met, and sita has least hypoglycemia. These agents act on different pathways. I told you 6 out of 8. Emerging evidence supports advocate for use of early combination as a potential. Below 7.5, 1 drug, metformin. 7.5 to 9, 2 drugs, metformin, pioglitazone. If you have between 9 to 10, you can use triple therapy right from the beginning, metformin, pioglitazone, as well as sitagliptin. Thank you for your patient hearing. If there are any questions, I'll be happy to answer your questions.
So, thank you, sir. Thank you for your insightful presentations. We will now take up the audience questions from the chat box. So, sir, I can see already a few questions are there in the chat box. So, first question was conventional versus modern triple combination. Which one is better?
So both are useful, right? So you cannot say only one is better. Let us say what is conventional and what is modern. The conventional, I told you already, metformin, yes, pioglitazone, DPP4, yes. In a patient who is normal weight, not obese, having urinary tract infection in the past or present, I would prefer this pioglitazone with metformin and sitagliptin. If the patient is young, up to 60, 65, I will use this combination. Suppose patient is more than 65, he may be having subclinical ischemic heart disease, I will not use pioglitazone. If the patient is very obese, I am hesitant to do. So in a patient who is obese, about 60 years, metformin, DPP4, as well as DPP4 inhibitor, SGLT2 inhibitors are an ideal combination. So you have a conventional one, MET, Pio plus Sita, or you have got a modern where you have got MET, DPP4 inhibitor plus ALT2. Depending on your patient, you can choose today EAST, AD, everything, individualization. You have a patient in front of you. You decide what is affordable, available, acceptable, adoptable. There is nothing like one combination for all. Today, you have got drugs with even sulfonylurea combination. You have got the sitagliptin as well as metformin and DPP4. Today, we are talking of pioglitazone, metformin, DPP4 inhibitor. You are the best judge, Pratima Singh, to decide which is the ideal combination, and you can decide, and you can use conventional, modern, depending on patient's choice. You tell them what is the advantage of this conventional modern, and you discuss with the patient. You are the one, patient says, Doc, you are the best judge. You can decide whatever.
So, there was one more question asking that in triple combination, there are several triple combinations that are available. So, they have mentioned combinations such as glimepiride, metformin, voglibose, glimepiride, metformin, pioglitazone, and modern triple combinations like sita-dapa-met or sitagliptin with pioglitazone and metformin. Which one is a better option?
Thank you, Dr. Ritvik, for all this combination. Very, very pertinent question, very important question, very intelligent question. Today, what we have is a cafeteria approach. When you go to cafeteria, what do we have? I have a coffee, I have tea, I have badam milk, I have juice. Which one is better? Sir, I am telling everything is good. What is your choice? Suppose you take one by one. Triple combination, glimepiride, metformin, voglibose. Glimepiride, when it is used in combination, will cause hypoglycemia. Metformin can go with anybody. Just like Joker in a speed card, it can fit into anything. Yes. Voglibose. If you look at voglibose, voglibose has to be given with food, not after food, before food. Glimepiride can be given before food, ideally, metformin after food. So when you have this combination, glimepiride, metformin, voglibose, glimepiride should be given 30 minutes before food, voglibose with food, metformin after food. When you will give this tablet, voglibose is the least potent one. If you use voglibose 0.2, 0.3, 3 times a day, you have to give with each meal. Giving this combination once or twice a day is useless. And what is the A1C reduction with maximum voglibose? 0.2 to 0.3. What is the side effect of voglibose? Gaseousness, bloating. So if you ask me, voglibose is most expensive, least effective, lot of side effects. So that's why I will never use it. And you cannot use once or twice a day. Glimepiride, metformin, pioglitazone. Yes, you can use. But when you add glimepiride to metformin, pioglitazone, please remember hypoglycemia is much more. Whereas metformin, pio, which is widely used, no hypoglycemia. Let us say patient comes to you, HbA1c level. Sir, you do anything. I will not take insulin. Then you can use glimepiride, metformin, pioglitazone. Then even 10, 11 can come down to 7. Sita, DAPA, metformin. Yes, as I told you, very good combination if patient is above 60 years and he has got urinary infection, he does not have urinary infection in the past, and he is obese, Sita, DAPA, metformin is good combination. Whereas if the patient is young and not so obese and maybe normal weight, underweight, I will use Sita, Pio, metformin. The elderly patient I will not use because if the blood sugar is above 200, you should not use dapagliflozin. If the blood sugar is above 200, I will use Sita, Pio, and metformin because as it is, they have polyuria and dapagliflozin curve. Any history of urinary infection in the past, don't use this. Then, if the patient is young and the blood sugar is the 200, 400, you can use Sita, Pio, and metformin. So again, we are coming back to Dr. Ritvik, individualization, patient in front of you, age, affordability, acceptability, adaptability, comorbid condition, obese, non-obese, liver is affected or not. If the patient has NASH, I will prefer pioglitazone over any other drug. So this is how you can choose your patient. One size does not fit all. So you have a different shirt, whether it is small, medium, large, XL, double XL also. Same thing, when the patient is sitting in front of you, you have got all the four. You are the best judge to decide, yes, I think this combination is the ideal for my patient. I discuss patient accept.
So, I know you have already shed some light on this, but there is a question asking what could be the ideal patient profile where sitagliptin, metformin, and pioglitazone can be preferred.
Yes, as I told you, the patient who has Sita, metformin, pioglitazone below 60 years and he is not very obese and he does not have heart failure and we don't want hypoglycemia, this is an ideal patient where I will use. Whereas Sita, metformin, glimepiride, I will use if HbA1c is 9, 10, 11, refuses insulin. This combination Sita, met is glimepiride because glimepiride, sulfonylurea is the most powerful. It can bring down, and especially the Sita, met, and glim can bring down 2.5 to 4 HbA1c level. I have seen that. Otherwise, somebody between 7.5 to 9, I will use Sita, met, and pioglitazone. Younger patient, not very overweight. That's what is ideal for me. And Dr. Nandishan also asked the same question, Sita, metformin, pio. That is what we have been discussing. Younger patient, not so obese, and HbA1c not high. Even up to 9, you can use this combination.
Sir, would this combination be useful in a patient who has NAFLD and type 2 diabetes?
Yes, because I told you, all these studies have shown that pioglitazone is the drug of choice if there is NASH, NAFLD. Okay? Non-alcoholic steatohepatitis, or please remember, there is a fatty liver. All of you see ultrasound, fatty liver. Every fatty liver will not become NAFLD, non-alcoholic fatty liver disease. So fatty liver is different from fatty liver disease. What do you mean by that? If SGOT, SGPT are elevated, then it is called NAFLD or MSALD, metabolic syndrome associated liver disease. When SGOT, SGPT are increased 2 to 3 times, if they are normal, it is only fatty liver, it's not NAFLD. Now you see steatohepatitis, it goes to next stage, fatty liver, MSALD, and MASH, metabolic syndrome associated steatohepatitis. Okay, next stage is cirrhosis. So we can see fatty liver, NAFLD, NASH or MASH, then you have got cirrhosis. The last thing is carcinoma of the liver. Every fatty liver will not become cirrhosis. Every cirrhosis will not become carcinoma of the liver. So these are all the stages. When you see from fatty liver, 25% of Indians are diabetics have fatty liver. Every fat person will have fat liver. What is the treatment? Treatment is just weight loss, lifestyle modification. When it goes to NAFLD or NASH or MASH, that is the stage you should use pioglitazone. When you already reached cirrhosis, neither SGLT2 inhibitors nor pioglitazone is helpful because it's a point of no return. So these are all the stages of liver disease. When to interfere, fatty liver only, lifestyle modification. NASH or NAFLD, you have to use pioglitazone or SGLT2 inhibitors also useful. There are so many other therapies starting from vitamin E therapy, 400, 600 milligrams. So many new drugs are coming. Lot of studies have shown SGLT2 inhibitors are also good even in NASH or even NAFLD acid. There was a paper last year, EDA, even in cirrhosis, where they used the SGLT2 inhibitors, mortality was less compared to those on SGLT2 inhibitors compared to those who did. Just a small paper, 50 patients. Still, we have not reached that stage. More and more data comes, we will know which is better. As of today, lifestyle modification, vitamin E, then you can use SGLT2 inhibitors and definitely pioglitazone. These are the ones. There is a question from Dr. Nandish. What is the ideal condition, Sita, met pio? I have already answered that.
So then, one last question: would this combination have any use in obese patients who are having insulin resistance?
Yes. See, as I told you, there is a fear always of side effect, increase in weight, and there are patients where it can cause edema, yes, anemia, and fracture in future. The last is bladder cancer. These are the five. Bladder cancer, I already told you, in India, we have got many of the meta-analysis to say that definitely it's coincidental and higher dose 28,000 milligram, which we never use. If you use up to 2 years, 30 milligram, don't worry about bladder cancer. Weight gain, there are some people don't gain even half a kg also. There are patients whom I have seen 3 to 5 kg. Edema, yes, but edema is not a contraindication to stop. If the patient goes into failure, you must stop because pioglitazone can worsen heart failure. So these are the fracture. If you are taking adequate care, lifestyle modification, doing bone density, using drug, and that too it is distal bones. It is not that you get femur fracture or whether it is spine fracture. So that way, this fracture, bladder cancer, these are not the things. Let us say you start pioglitazone 15 mg, go to 30 mg. He gains more than 3 kg. One thing, either it can stop pioglitazone or SGLT2 inhibitors. When you add SGLT2 inhibitors, that 3 kg of weight gain may not occur. He may even lose weight. So that's why metformin, pioglitazone, SGLT2 inhibitors in obese is also a good choice.
Thank you. So thank you for answering all the questions. We are nearly at the finish line, but before we can conclude, let us express our gratitude to all those who made this program possible. For this, I would like to invite Mr. Pawan Pandey, Marketing Head, Research, Emcure, to give the vote of thanks. Over to you, Mr. Pawan.
Thank you, Dr. Tanmay. First of all, I would like to thank Channa Kumar, sir. Thank you, sir, for taking out time late evening and sharing your clinical feedback, also answering all the queries. I'm sure it will definitely help all the audiences to take clinical judgment in type 2 diabetes management. I would like to thank all the delegates to be present in late evening. I'm sure you have got clinical experience from Dr. Prasanna Kumar. I would also like to thank medical team of Emcure for making this event successful. So thank you, Prasanna Kumar, sir, and we'll surely hope that in coming scientific events also you will definitely help us and share your experiences whenever will be required, sir.
Thank you. Good night. Take care. Bye.
Thank you, sir.
Thank you so much, sir.
Thank you,
Thanks,
sir.
sir.
Good night.
Thanks.
Good
Thank
night.
you,
Thank
sir.
you. Thank you.